Tengo el enorme placer de presentar al doctor Weinshenker, que va a dar la presentación sobre cuándo y cómo deben ser evaluadas las recaídas en enfermedad del espectro NMO, consideraciones prácticas, que sin dudas es un aspecto esencial del manejo de los pacientes desde el consultorio. El doctor Weinshenker es profesor de neurología y consultor del Hospital UBA en Charlotte, Virginia, y por supuesto es un reconocido experto en enfermedad del espectro NMO con una trayectoria muy larga desde la Mayo Clinic. Adelante, profesor Weinshenker.
Hello, everybody. It's a pleasure to speak with you today. I'd like to thank Liliana for moderating the session and Edgar Carnero for inviting me. And I've been asked to speak to you about the evaluations of relapses of patients with neuromyelitis optica spectrum disorder, and to make this practical. And today, I'm really going to concentrate on identifying relapses, say, in a clinical trial of patients who already have an established diagnosis of NMOSD. So we won't really be discussing differential diagnosis, but in patients with known NMOSD, how do we detect and evaluate relapses? Attacks in neuromyelitis optica are the signature aspect of this disease. This is a disease that does not result in progressive disease, but really causes attack-related worsening. And I've classified attacks in two groups: typical, which would account for 80 to 85% of the attacks that are experienced by patients, certainly patients in clinical trials. These include optic neuritis and myelitis. Typically, the myelitis is severe and associated with long spinal cord lesions. But of course, these are similar to attacks that occur in multiple sclerosis. But there is one very unique form of attack that accounts for up to 15 to 20% of the attacks, and that is the so-called area postrema syndrome of intractable nausea, vomiting, and hiccups, something that we didn't recognize until we were able to differentiate neuromyelitis optica from multiple sclerosis. And then there are the atypical attacks that account for perhaps 10 to 15% of attacks. And although they occur infrequently, a number of them, for example, attacks that relate to involvement of circumventricular organs like the hypothalamus and thalamus, are fairly distinctive for neuromyelitis optica spectrum disorder and are rarely seen in MS. And lesions in these locations produce clinical manifestations such as narcolepsy, eating disorders, endocrinopathies. Some that target the brainstem may be similar to attacks seen in MS. When the brain is targeted, often clinical manifestations are diffuse because the lesions are fairly large, either large lesions in the corpus callosum or ADEM-like lesions that produce encephalopathy, but they may produce multifocal and focal clinical manifestations as well. Many of you who have experience with neuromyelitis optica will know that attacks often occur rapidly and produce severe disability. So why is this a difficult thing? Why do we need specific, sensitive, and rigorous criteria for NMO spectrum disorder relapses? Well, it is the primary manifestation of neuromyelitis optica and the main endpoint in clinical trials. So it's very important that we can evaluate these events very carefully. Furthermore, although it might seem easy, as I will show you, 30 to 50% of clinical events that investigators report in clinical trials are not ultimately adjudicated as relapses in recent clinical trials. Because patients are encouraged to present very early without fully developed syndromes, and because we have to treat patients as soon as we suspect they are having a true attack, it may be tricky in those very early stages of an attack to reliably identify it as one. And in clinical trials of neuromyelitis optica, patients typically are allowed to have only a single relapse. And then they are taken out of the randomized portion of the clinical trial, often enrolled in an open label extension. So patients really contribute only a single data point. And therefore, it's very critical that that be reliable. Furthermore, as we'll talk about, we have a tendency to want to, for obvious reasons, compare the results from trial to trial. And therefore, it's very important that if we're going to make these comparisons in a reliable way, similar and rigorous methods were used to identify a relapse. We don't want to have a situation where an event in one clinical trial is considered a relapse, and in another clinical trial, because of the way that the relapse was identified and adjudicated, it's not considered a relapse. And so here is a slide that I think many of you have seen. This is a slide that I put together comparing the results of 4 phase 3 clinical trials that led to approval of 3 agents by regulatory authorities in many parts of the world: eculizumab, inebilizumab, and satralizumab. And what I'd like to point out is if we look at the proportion of relapse reduction, specifically in the AQP4 positive patients, because these drugs have only been approved based on their efficacy in this subgroup, you can see that the proportion reduction ranges anywhere from 74 to 94%. Now, are those differences really meaningful? Well, I think you can see that there were differences in the way the trials were conducted. In some of the trials, patients were allowed to stay on background immunosuppression. Others were pure placebo in the sense that such background immunosuppression wasn't allowed. There were differences in the enrollment criteria. But in the end, can we make these comparisons across clinical trials to say 94% is better than 74%? And this came up in particular as a result of a recent publication from many of the investigators who were in the eculizumab clinical trial. They conducted a so-called network meta-analysis and contended that eculizumab treatment may prevent NMOSD relapses more effectively than the other treatments. And this led to a letter to the editor, of which I was a co-author, and a response from the original authors. And what did they show? They showed in their network meta-analysis that in particular in the patients who did not receive background immunotherapy, the hazard ratio of experiencing an attack, or the reduction in the risk of an attack, was much better for eculizumab versus either satralizumab or inebilizumab. And when they considered all patients, they found similarly that eculizumab seemed to be better. Well, we pointed out a number of limitations of this approach, some of which don't directly pertain to relapse adjudication, but we mentioned that there was a difference in the exclusion for patients who had previously been on rituximab. It was 6 months exclusion for inebilizumab versus 3 months in the eculizumab study. And there was actually a difference in the proportion of patients who had previously been on rituximab. So that was one point. There were differences in the sample size, of course, which changed the power. But as is pertinent for this talk, the attack criteria seem to be much more precise and well laid out in the inebilizumab study. There were 11 specific criteria for optic neuritis, for myelitis, 2 for brainstem, and 1 for brain. And all patients had neuroimaging of all parts of the neuraxis, and based on the presentation and the clinical findings, if they did not meet a certain threshold, investigators were given access to the MRIs to give them an additional opportunity to adjudicate an attack. In the PREVENT study and in the SAKURA studies, imaging was not routinely performed and not necessarily considered. In some of these studies, if imaging were available, it was made available to the adjudicators. And as you can imagine, this would lead to presumably greater variability in the ability to get a precise adjudication for attacks. So as I mentioned, the criteria in the N-momentum inebilizumab study, in my opinion, were more precise. They did provide MRI confirmation and equivocal cases, improving both the specificity and sensitivity, and this was done in real time, as opposed to the adjudication, which was done retrospectively in the other 2 clinical trials. And therefore, attacks were less likely to be rejected in secondary review. So say, for example, in the inebilizumab study, of 22 investigator-determined events, the adjudication committee adjudicated 18% of them. Only 13.6% were rejected. By comparison, of 14 events that were reported as attacks by investigators in the PREVENT study of eculizumab, only 3 were confirmed. In other words, 78.6% were rejected. It was the AC-based adjudication that was accepted, but ideally, if we had good criteria, there should not be such a big difference between events judged as attacks by investigators and by the adjudication committee. And the results were intermediate for the SAKURA studies. So the basic point for this talk is what was counted as a relapse in one clinical trial might not have been counted as a relapse in a second clinical trial. And for this reason, a number of NMO investigators working under the auspices of the Guthrie-Jackson Foundation have been working on a project, and that project is known as DSNR, Diagnosis and Severity of Neuromyelitis Optica Relapses. And the goals were to define the process and criteria to determine the adjudication of an NMOSD attack, assign its neuroanatomic localization, and categorize its severity. This was primarily designed to be a tool in clinical trials, but we thought that it could also be useful for other types of research, observational and retrospective study, and even be useful in clinical practice. We had a number of focus groups, one that concentrated on the optic nerve, another the spinal cord, a third brainstem and area postrema attacks, and a fourth brain attacks. And we had an MRI consultant, Dr. Islam Izbudak, from Johns Hopkins University, who was extremely helpful in considering the role of imaging. The principles were to concentrate on the targeted neurologic deficit, and I think this is really quite important. For example, the satralizumab clinical trial used EDSS and functional scores, but say, for example, if you have severe blindness in one eye, you already start out with a very high score. And if the patient develops a new attack in the opposite eye, there's very little sensitivity or change that may occur in that functional system score. But really what you're interested in terms of identifying the relapse and determining if there's improvement, is not what happened to the other eye a long time ago. You're interested in the targeted neurologic deficit, the deficit in the new eye. and we're interested in change compared to baseline. We've decided to focus on a limited set of examinations. Some of these clinical trials had very large set of clinical findings that were evaluated. We wanted to be comprehensive and be able to include all relapse phenotypes, including area post-streama syndrome, and the hypothalamic and circumventricular organ syndromes. They were uncommon, relatively speaking, but we thought they should be captured. We wanted this to be short, and we felt that efficiency would improve both compliance and completeness of doing all the aspects of the exam and also the precision. We wanted it to be simple and the rules for adjudication to be largely invisible to the end user by creating an electronic tool where the algorithm for adjudication based on the raw data was done in the background. We wanted the evaluation to be predominantly clinical, but to allow for MRI adjudication in borderline cases, as was done in the inebilizumab clinical trial. And we thought that this should be doable in real time, but still subject to AC review. Hopefully, the number of times where the adjudication committee would overrule the investigators would be very few if we made it precise, but there are always extraordinary circumstances that require interpretation of a person. So again, the goals were to identify with high precision whether an event was a relapse or not relapse, to identify, and this is not always easy, say, for example, if a patient has weaknesses in spinal cord or brainstem or brain. So we wanted the tool to be able to do that, again, in a very precise way, and also to classify the severity of an attack based on change from baseline. And we thought this is very important because treatments might not only prevent attacks, but some, even if they can't prevent attacks, may mitigate the severity of attacks. So to be able to classify severity was felt to be important. And this shows a couple of the algorithms, one on the left for adjudication of a transverse myelitis, on the right for optic neuritis. Say, for example, if we go on the left into the myelitis module, there are symptoms which trigger the evaluation. Originally, the adjudication would be done on clinical criteria if a clinical threshold is met. But if the patient had suggestive symptoms or mild findings not enough to adjudicate based on clinical criteria, then the patient's imaging would be reviewed. And there were certain criteria, largely if there was a new or changed T2 lesion or gadolinium enhancement, that would allow one to make a diagnosis of transverse myelitis. But if it weren't transverse myelitis and the findings were very convincing, then perhaps the patient should be evaluated and an MRI of the brain done to rule out a brain or brainstem lesion that might be responsible for the findings. A very important question is, how sensitive are clinical criteria? And is there anything we can do to enhance sensitivity? In the inebilizumab study, which has been very extensively mined to get very important, useful information to enhance adjudication, 41 out of 43 were associated events, that is, 41 out of 43 AC adjudicated or adjudication committee adjudicated attacks were associated with either MRI changes or elevations in serum GFAP, a structural protein of astrocytes that's released and measurable now with Simoa technology in the blood. Most of these, in most cases, the MRI was the most sensitive, and we had 14 patients, only MRI lesions, but not SGFAP elevation was seen, and one patient had elevated SGFAP only. But perhaps even more interestingly, on the right, you can see that although in adjudication committee adjudicated attacks, SGFAP was elevated in the majority, whereas in investigator-determined attacks that were not confirmed by the AC, there was only one patient with an elevated SGFAP. There were other participant-reported symptoms that were not even judged by the investigator to be a clinical attack, and yet there was elevation of SGFAP. And so I think one could wonder whether some of those might in fact have been attacks that were missed, and can we potentially, using these biomarkers, make criteria that are even more sensitive for the future? So future considerations, because head-to-head trials will be very, very difficult unless we can substantially improve the sensitivity, either by considering severity as part of the outcomes, or coming up with more sensitive ways to pick up attacks, such as using MRI. Unfortunately, well, I don't know whether it's unfortunate, but very rarely do we see silent MRI activity in NMO. Seems like occasionally we do, but this is quite infrequent. And what about biomarkers? Because experience from the inebilizumab study suggests that we can identify elevations of SGFAP beginning about a week before a clinical attack. And further study of this measurement may be helpful. So in conclusion, attacks of NMOSD are generally recognizable clinically. For clinical trials, when patients present early, we need sensitive, reliable evaluation protocols that we can apply with a high degree of consistency. And this is going to be particularly important to make comparisons across clinical trials. I believe it's going to be important to reliably measure attack severity for each attack, and that may improve our sensitivity, especially if we're considering head-to-head clinical trials in the future. And MRI and SGFAP are potentially helpful in improving sensitivity and certainty, certainly in patients whose clinical findings do not meet a sufficient threshold of confidence that you can reliably say that this is an attack. In those situations, MRI may be substantially helpful. And on that note, I'd like to thank you for your attention.
Thank you, Professor Weinshenker, for this amazing presentation. And now I have a few questions for you. Why do you think is the real cause? Because 30 to 50% of clinical attacks are not adjudicated as relapses in recent clinical trials, because of the patients, because of the clinical doctor, because of the committee that have to adjudicate the relapses, because we usually think that a clinical relapse in NMO spectrum disorders are enough severe, and I presume I can easily recognize this event. What do you think about this?
Yes, thanks very much. I would say the first issue is that there's a different perspective between the investigators and the adjudication committee. Investigators are caring for those patients, and generally they would have the bias of, I'd like to give this patient the opportunity to have steroids, I'll call it a relapse, and I will treat it. And sometimes they may even have doubts in their mind because they have mainly symptoms. The findings are very subtle or minimal. Whereas the perspective of the adjudication committee, and that's why I think virtually all the trials, even when they didn't start out with an adjudication committee, created one. The adjudication committee is not caring for that patient. Their focus is the scientific integrity of the study. So I think we're just seeing some of that dichotomy between how the investigator looks at it and the adjudication committee. But, clearly based on the means and the protocols that were used in the different clinical trials, there was difference in the proportion of events that were adjudicated, saying that this really depends on how rigorous we are. And say, for example, we've seen, and I know as being a member of the adjudication committee of several of these studies, patients who may have mild changes in vision, not sufficient to meet the criteria of the clinical trial. But if you do an MRI and you see a very clear, long enhancing lesion in the optic nerve, you can say that this was adjudicated. So I think particularly for these mild early events, including MRI, may improve the sensitivity. So I think that's part of it too.
Yes. Okay. Perfect. And do you think we need to perform an MRI in every clinical attacks instead of use only our neuroanatomical localizations? It's really need to perform an MRI in every relapse of NMO, considering the cost, the accessibility. It's different in different areas of the world.
Yes, I think that's an excellent question. And I certainly don't do that in every patient.
Yes.
And I think certainly for clinical practice, somebody comes in with typical symptoms and there are some objective findings. And sometimes we'll say, well, 5 days of steroids, even if I'm not sure, I'll err on the side of treatment. And I think that's perfectly reasonable. But I think if we're doing a clinical trial that is going to influence the decision whether to approve, especially since only one event is allowed in NMOSD before the patient leaves the randomized portion of the trial and goes to the open label extension, we have to be very precise. And I think we can establish clinical levels of certainty if they have a certain degree of change, if they go from 20/50 to no light perception and they have a new afferent pupillary defect. I don't think that you need an MRI, even in a clinical trial in that situation. But if there's a 2 or 3 line change in visual acuity, and you're not absolutely certain, I think doing an MRI in a clinical trial is probably pretty important.
Yes. And from a clinical point of view, do you think that every relapse of NMO spectrum disorders need to be treated with corticosteroids or plasmapheresis, or we need to consider its severity to determine the necessity to initiate a treatment?
Well, I think it is different than MS. In MS, I think we have greater latitude in observing and seeing how things go. Certainly, there are milder relapses among NMO. And now that we are observing patients and more and identifying more patients, we recognize not every relapse is severe. But I think every relapse has the potential of being severe. And we have a lot of suggestive evidence. I wouldn't say it's definitive evidence, but that if you avoid waiting until there's bad deficits, that you may be more successful. So I do think we should be treating every patient as promptly as possible with NMO, just because we can't be sure if that attack will evolve and become severe.
Yes, I absolutely agree. And this is my last question. Do you think that biomarkers just GFAP in serum is the future to identify a relapse?
I don't know if it is the future.
Yes.
Theoretically, it can give you some early warning that a relapse is coming, but just, can we be doing blood work on a regular basis? It's hard to know. It was interesting in the inebilizumab trial that even at the baseline, it was about 20% of patients had high levels, and they had a higher risk of attacks throughout the whole trial, even though this was done just at the baseline. So, I think we're talking now in epilepsy about forecasting seizures. We can't predict what's going to happen tomorrow, but we can forecast for the next several months that the patient's at a higher risk. Maybe we can prioritize and forecast that, patients who have a high baseline SGFAP are at higher risk. I'm talking, of course, with fairly few data. That this is really in its infancy, but I think it does give us tremendous capacity, because it's finally we can measure a very specific astrocyte marker in the blood, and I'm hoping that this will be able to be exploited either in detection of or maybe forecasting for attacks.
Yes, perfect. So I want to thank you for this wonderful session, and it was a tremendous pleasure for me to share with you your talk and this discussion, Professor.
Thank you, Liliana.